Well, good afternoon, everyone. This is Mike Stull, Chief Strategy Officer at Employers Health, and thank you for spending an hour of your day with us as we discuss some of the key concepts around PBM contracting. Today, I'm joined by Dave Uldricks, Vice President, PBM Contracting and Strategy at Employers Health. And Dave is an attorney on our team who I've worked closely with over the past dozen years. Dave is our lead negotiator with our PBM suppliers and manages all aspects of our contracting process. Before we get started, I hope that you and your families and friends and coworkers are all staying safe and healthy as we deal with the new realities that we face together as part of this COVID-19 situation. As we adjust to holding more meetings online, I hope that technology cooperates with us today. But if you have any difficulties hearing or seeing me, please either raise your hand or you can send a message to Emma, who is working behind the scenes and can assist. A few other announcements before we begin here. So we have a few upcoming Sightlines webinars later this week and again on May 19th that opine on current marketplace dynamics related to pharmacy benefits. We also have the third in our PBM webinar series on May 5th, where I'll be joined by Matt Harmon from our clinical team, and we'll take a deeper dive into specialty pharmacy. A reminder, you can go back and listen to the first webinar in this series at our website by following the link on the screen here. You can also see a listing of all of our upcoming programs on our website at employershealthco.com/events. Again, that's employershealthco.com/events. I'd also encourage you to listen and subscribe to our podcast, HR Benecast, which we release every other month. Our latest episode was a conversation that I had with Kelsey Dieters from our clinical team on the topic of gene therapies. And our next episode will feature Fo Burke, who's the CEO of National Accounts for United Healthcare. A special thank you to the many organizations that provide financial support for our learning and networking programs during the year. Obviously, without their support, we can make all of these programs happen, so thank you. And as we look at our agenda today, just a reminder, all attendees are currently in listen-only mode. If you have questions, please send those using the question function in your control panel. We'll look forward to addressing all your questions at the end of the presentation, and if we run out of time today, we'll send you a response after the meeting. There's also a handout section in the control panel where you can download a copy of today's presentation. And upon exiting the webinar, you'll receive a survey to provide feedback. We appreciate all attendee feedback in order to provide future valuable education opportunities. And certainly in the situation where we're dealing with a lot of these virtual events, suggestions you have in terms of how to improve the virtual events is appreciated as well. So today's topic on contracting, we could spend hours, if not days, on this topic, but we only have 1 hour, so let's get started. And we'll start with a slide that I like to start all of my presentations on, which provides some context into what you'll hear today. Our opinions are shaped by the experiences that Dave and I have had working collaboratively with our clients and their consultants and the 3 PBMs that we contract with. Those contracts are utilized by 225 plan sponsors across the country and provide benefits to more than 1 million lives. We've seen a lot of growth in the past year and a half, about 260 million, which has brought our total collective spend to about 1.5 billion. The mid-year for this year has actually been one of the best that we've ever had in terms of adding new groups to our program. And I'm especially proud of this growth when you consider the fact that nearly all of it is through a competitive RFP process run by independent third-party consultants working on behalf of their clients. We have to prove the value of our contract to these independent evaluators, and our internal team is both competent and diverse, including attorneys like Dave, a growing team of clinical pharmacists, data analysts, I should say, and account management professionals. So let's start with a bigger picture as we look to better understand how PBM contracts work. I've used this homemade graphic a few times to try and illustrate my understanding of it, so hopefully you appreciate it as well. There are many medications, obviously, out in the marketplace that are available for patients to use. And your plan uses tools like the formulary, clinical management programs, and plan coverage decisions to determine which of these medications ultimately get dispensed to your plan participants. Your contract, in particular the definitions within your contract, will sort these medications into groupings of claims or buckets of claims for purposes of pricing. In many PBM contracts, this includes distinguishing claims by the channel they're dispensed through, retail, mail, and specialty, as you can see on the drawing there, and also by whether the medication is a brand or generic. The standard pricing guarantees within your contract then measure the actual discounts, fees, and rebates that your plan achieves for these groupings of claims and reconciles them to the guarantee, ultimately determining the total cost for the plan. So again, in a way, your contract acts as a filter. Once these claims get through formulary, clinical management, and some of the other edits that you have set up as part of your plan, the medications that get through then are filtered into these different groupings of claims, and then the pricing that you've negotiated as part of your contract are applied to these groupings, subject to different caveats, I should say, that are contained within your contract. So that's it from a big picture. Let's think about some decision points and some common decision points that plans make that have an impact on what form your contract will ultimately take. And I want to highlight 4 of them for you today. The decision to carve in versus carve out, to pursue a traditional or spread model versus a pass-through model, who you select as your consultant to help you evaluate, and whether or not you decide to contract through a coalition or directly with a PBM or health plan. We've covered some of the decision points around carve in versus carve out on our first webinar, and again, you can revisit some of the decision points by going back and listening to that. I also have them listed again here in this table. I think that obviously recent acquisitions in the marketplace have aligned PBMs with large health carriers, CVS with Aetna, ESI with Cigna, OptumRx with UHC. Anthem relaunched its in-house PBM IngenioRx and tapped CVS to help it better scale and network and rebate contracting. Similarly, Prime Therapeutics, which is owned by a multitude of Blue Cross and Blue Shield plans from across the country, entered into a relationship with Express Scripts Cigna to enhance its leverage. And as someone who today works with clients that carve out the PBM relationship, even with 2 of the large PBMs I mentioned above, I think there are a couple of observations, at least that I've made. First, pricing to employers has always been re-underwritten by the health plan so that they can keep a piece of the pie. So an individual employer is part of underwriting really twice. Once when the health plan is underwritten by the PBM, and the second time when the health plan underwrites the individual group. This can mean less aggressive pricing and a whole host of cross-subsidization maneuvers between medical and pharmacy that create favorable optics in terms of pricing. Second is the idea that integrating data for effective patient and utilization management is only achieved under a carve-in arrangement. If we look at the organizations in the marketplace that are winning business for their services that relate to employee advocacy, employee engagement, and disease management, they don't own a PBM nor a health plan. They take the data, which are processed on two separate claim systems, and combine it within their platform to provide the services to plans and their participants. It's not really a question of whether health plans can do the same, it's whether they will do the same. And so I don't believe that it's integration by itself that will improve the quality of services nor the ultimate cost. It's really what they do with the data versus where they get it. So I think that's an important distinction when thinking about the value of integration. Taking carve-out a step further, some plan sponsors are considering carve-out of certain PBM functions, like specialty drug dispensing, specialty prior authorization, formulary and rebate contracting, and network contracting. And these are all areas where we at Employers Health actively evaluate opportunities, and I can share what we found. On the specialty dispensing side, I think we can think about it in a couple ways. First, does it make sense to carve out all specialty from being paid under the medical to the pharmacy benefit? No, it doesn't. You need to understand what's being paid for under both sides of the benefit and how and where it's being reimbursed. Then you can make a determination of the best site of care and direct coverage to either the medical or the pharmacy plan. Second, the second piece of this is, should I carve out specialty dispensing from my PBM to an independent specialty pharmacy? And what we found here is that it's very difficult to carve out all specialty dispensing, particularly if you're currently in an aggressive deal from one of the big three PBMs. Specialty pharmacy, like all other aspects of the industry, is driven by volume and access to specialty medications. 3 of the 4 largest specialty pharmacies, I should say, are owned by the big PBMs. CVS, obviously, by CVS, Accredo by Express Scripts, and Briova, which is now called Optum Specialty by Optum, and Walgreens is the 4th. Typically, when you carve out specialty or open specialty to retail, you take less aggressive financial guarantees. And again, if you're in an aggressive deal today, it's tough to make the economics work, which is what we have found out. I do believe there will be opportunities to carve out specific classes of medications to more holistic providers that offer a capitated solution for all of the services needed by a patient, including medications, and we see this today in the infertility space. On the specialty prior authorization piece, we know that there's an inherent conflict of interest for PBMs when they dispense medication through their own specialty pharmacy, and then also make the determination on whether the medication should be dispensed in the first place. PBMs counter that if they're not effective with prior authorization, then their claims costs are going to be out of control, and they will lose more than just the specialty piece of the business. And I think, like most things in life, the truth is somewhere in the middle. So here's what we have found is that prior authorization criteria are heavily tied to rebate contracts. And if you carve out this function, you can expect to receive lower rebate guarantees. However, if you can avoid paying for a high-cost claim altogether, well, then that's worth more than a rebate. We've also found that the criteria that PBMs use are, generally speaking, pretty good. Some outsourced vendors create stringent criteria that deny claims, but only have them overturned by appeal, which in that case, you've simply added administrative costs and prolonged the process for the patient. Still, we know that PBMs aren't documenting or following their own criteria as closely as we'd like. So here's what we're doing. First, our clinical team reviews the PA criteria set by the PBMs for reasonableness. Second, we're working with our PBMs to accommodate a third party to conduct a concurrent review of certain specialty medications that meet a dollar threshold. We utilize the PBM's existing criteria and ensure that the PBM has documented that the patient meets those criteria before the drug is dispensed. We believe this is a prudent step for those plans that are concerned about the inherent conflict and want to ensure that the PBM is following its own set criteria without taking a financial hit from rebate adjustments. From a formulary and rebate perspective and from a networking perspective, I mentioned earlier that companies the size of Anthem and Prime Therapeutics are turning to CVS and ESI for leverage. And given our size and our deal, we have found it very difficult to make the economics work by contracting out these functions. I think it's important to remember that most of the large PBMs offer, including the ones that we work with, offer more restrictive formularies, and very few actually utilize those formularies. So again, just an observation from our side. So it's time for a poll question, and let me launch this. So the poll question is, with price being equal, what is the most important factor in determining whether to carve in or carve out? So I'll give you a few seconds to answer that and grab a quick drink. Give it a few more seconds. They're coming in hot. All right. So what the audience, let's see if it'll share these. There we go. So in terms of the audience response, so participant experience and plan flexibility and utilization management really came in nearly tied. So thank you for those who voted. And I would say that this is pretty consistent with what we hear on a regular basis as well. All right. So that was carve in versus carve out. The second decision point has to do with the pricing model, whether traditional or pass-through. Again, we covered this on our first webinar, so I just want to revisit a few key points. First, let's make a distinction between elements in your contract that deal with the adjudication price versus the reconciliation price. Most of the pricing that we are familiar with in the contract deal with reconciliation. Your discount guarantees, for example, are the average of the actual discounts adjudicated at the time the claim was dispensed. And there are very few places within your PBM contract where we negotiate specific prices for specific drugs at specific times. There are concepts such as lowest of logic or MAC pricing that set guardrails around how drugs will price at the point of sale, but typically offer little specificity without ample caveats. I bring this up because I think it's important to distinguish for purposes of determining whether a pass-through or a traditional model is best. Most evaluations are focused on reconciliation guarantees, but I would contend for a pass-through deal, a true pass-through deal, I'd be much more concerned about how claims are priced at the point of sale or the point of dispensing. This is because under a pass-through deal, I, as a plan sponsor, am taking on more risk for my plan's utilization in drug mix, which ultimately play into the guarantees the PBM offers you. Much of the decision point has to do with who wants to take on the risk for these variations in channel and drug mix. For example, an open network has more potential for variation than a closed network. A small group has more risk, and the slightest variation, so for example with a new specialty medication, can have a larger impact on results. The ability to offset guarantees provides more flexibility to absorb risk by the PBM. So how might this actually play out in real life? Let's look at this simple example. In it, utilization occurs in varying degrees across 3 pharmacies with varying reimbursement levels. Based on where utilization occurs today, the blended rate would be about 17.7%. Because the transparent model is passing through its arrangements with little ability to offset, it sets its guarantee at 17%. The traditional PBM, which keeps the upside when your utilization occurs over on the left at Pharmacy 1, can use that and other sources of spread to offset the shortfall of claims that would occur, for example, at Pharmacy 2. Hence, it can offer a guarantee of AWP minus 18%. The value of the pass-through arrangement is really knowing that Pharmacy 1 is the cheapest and making design changes that help drive utilization to that particular pharmacy. Otherwise, the plan's better taking the traditional guarantee there at AWP minus 18%. It also matters the size of the PBM. So this is one of my new diagrams, and the first one I put out, our marketing team said, oh, we've got to do something with that. So they've made it look a little bit more pretty. But it matters because remember that the PBM can manage its reimbursement guarantees across its entire book of business. Because we typically don't specify the actual prices that drugs are adjudicated at, it really leaves open the opportunity to alter reimbursements based on the pricing guarantees that the PBM has with its larger book of business. Someone go on mute there, sorry about that. Obviously, the larger the PBM, the more flexibility that it has, and some PBMs, to make things more complicated, some PBMs also utilize multiple network contracts, making it harder to overperform the guarantee you'd otherwise get in that traditional arrangement. So hopefully this was useful in trying to visualize that concept. Rebates can also be handled differently under a traditional versus a pass-through arrangement, although we see many contracts moving to a hybrid of the two. And so the key takeaway here is that when I'm asked which model is better, I usually answer with, it depends. It depends on the client. It depends on the PBM. It's why we offer both models and why we offer contracts with both the large PBMs and more of a mid-market PBM. The next decision point has to do with who you have help from to negotiate and evaluate your contract, so consultant selection. And I just say, remember that, we come across a wide variety of consultants out in the marketplace, and rarely is the health consultant also the pharmacy consultant. The national consulting houses have or are developing national pharmacy practices to serve their clients. There are standalone pharmacy consultants who either work directly with employers or serve as a consultant to consultants. There are suppliers like TPAs who act like a consultant but end up pushing their own relationships. And there's also organizations that promote specific PBMs while also claiming to be a consultant and running bids and evaluations that are typically laced with huge fees. Speaking of fees, we see typically a variety of ways that the consultant can be paid. Some of these are more straightforward than others. But there are a lot of great consultants out there, and we have the pleasure of working with a lot of them on a regular basis. Like any other group, there's also some bad apples, and certainly we see more of those than we'd like to. I come across those who want to push their groups into their own collective, and that's particularly within the large consulting houses, although it depends on office. And that's a conflict of interest, pure and simple. Another one that I hear a lot is that the PBM will pay for my consultant. And we work with a lot of consultants where we build in the consultant's fee as an administrative efficiency, but it's typically paid for through the pricing. So I think the old saying that there is no such thing as a free lunch applies here, but there are certainly prospective clients that we come across that think that that's the case. There's a host of other scenarios here, but the bottom line is there are a lot of qualified consultants out there who do very good work. And while this may, I guess this is would completely be a biased statement, but if you're an existing client of ours, you've likely found one of those qualified consultants. I guess you could say that most clients of Employers Health use good consultants, but not all clients that use good consultants are clients of Employers Health. So there are a lot of great ones out there, but just beware of some of the bad apples that we've come across. All right, finally, before I turn it over to Dave, I want to take a look at the decision of a coalition versus going direct. When you examine the contracting process as a one-time event, large employers may think that they can match a coalition deal. I've been doing this for over 15 years now. Almost every time the value of the coalition comes in really over that period of time, whether it's 3 to 5 years or even longer. That's where the true value of the coalition really shines. And the coalition always outperforms a standalone for the groups that we're looking at, which today can be as large as 70 million or greater. Perhaps the better question is how the different coalitions vary, and there are certainly some similarities in terms of conducting a market check or an audit, but the pricing value among coalitions can be very different, and the additional support can be very different. And many of these differences come from who the coalition's ultimate loyalty belongs to. In our case, we were founded by employers for the benefit of employers, but there are other coalitions out there that have outside owners like publicly traded hospital systems, private equity, consulting houses, as I mentioned, or even are stood up by the PBMs. So again, to use another old saying, if you've seen one PBM, if you've seen one coalition, you've seen one coalition. So with that, I will stop and I will turn it over to Dave to take us from here.
Okay, great. Thanks, Mike. That's really good information. Thank you for that. Hopefully a lot of the things that I have to say here today will sort of mesh with what Mike has said. But again, I'm Dave Uldricks. I'm the Vice President of PBM Contracting and Strategy for Employers Health. I've been with the coalition for about 12 years. Prior to that, I worked at a smaller PBM that eventually became one of the large ones. Worked there since 2000, and my role there was negotiating with pharmaceutical companies for rebates and also doing contracting there. So over the past 20 years, I think I've learned a few things about contracting, which I'll try to convey to you today. First, we're going to talk about some contracting tips. Then we're going to get into some of the basic elements of PBM contracts, and then with time allowing, we're going to really dig into some of the more important parts of PBM contracting, and that's some of the pricing terms that Mike mentioned earlier, and then the definitions as well. So since I'm Mike's host, he's driving, and Mike, if you wouldn't mind, please go to the next slide. So on this slide, there's a number of things that are, I think, pretty much common sense for really any negotiating endeavor. I think the thing that is not on here that really bears mentioning is at least 90% of the time spent in PBM contracting is really spent not even interacting with the PBM. It's really spent preparing for interaction with the PBM. Preparation is key in any contracting negotiation, and certainly that's where we spend the majority of our time, is doing some data analytics, trying to develop our template for how language should read. So those types of activities are really occupy the majority of our time. But I think the other thing that's important to know about PBM contracting, which I think is a skill set that's integral to the activity, is you really need to know the math if you're going to engage in PBM contracting. If that's not a strong suit of yours, then certainly you need to have a team member that is good at that. A really strong algebraic skill set is critical to good PBM contracting. Next slide. So right here, these are the basic elements of the majority of PBM contracts that you will see. I've bucketed them into three groups, which are important terms, services and obligations, and key terms. And we'll go through each of these in some level of detail. But one point of note from a PBM contract construction perspective, for the most part, everything that you see here will be contained in one base or core agreement, with the exception of the pricing terms and conditions. Typically, those are handled in an exhibit or an attachment, something at the end of the PBM contract. And I think that suggests something. Certainly that suggests that it is the most fluid portion of the PBM contract. It's something that the PBM has a lot of flexibility with. And I think it also suggests that it differs from client to client quite a bit. That doesn't have any impact or bearing particularly on any one deal, but I think it is an interesting point. Next slide, please. So these are the important terms, and all of them are obviously important. Term and termination is important to any contract. Invoicing payment certainly is important too. In the PBM world, use of data is important. You want to know how your data is being used by the PBM and making sure that they use it appropriately. Confidentiality provisions are important and should be observed. But the one provision in this bucket anyway that I want to point out is general provisions. A lot of time people will overlook general provisions. It's typically at the end of the contract, and a lot of times it contains terms and provisions that people generally think aren't all that important, like acts of God and things like that. In a PBM contract, though, this is where a lot of terms often hide that either modify a previous definition or may incorporate fees that you were unaware of. So this is a section that I think that most clients and consultants should pay particular attention to, because it can be a place where a lot of unexpected terms introduce themselves. Next slide, please. These are the services and obligations of a PBM contract. Typically, this is not an exhaustive list. It is a list of those services and obligations that should be in most, but there certainly can be others. I think on this list here, most of it is pretty self-explanatory, but the one area that Mike alluded to earlier, but I'll mention again, is under PBM services and description. And that is make sure that your contract has lower of logic. And that's the logic that ensures that as a plan, you're paying the least of the discounted cost plus dispensing fee, MAC plus dispensing fee, or the pharmacy's usual and customary price. And that should be coupled with provisions that also ensure that the members pay the least of the cost share, discounted price, or the pharmacy's usual and customary price. Employers Health has had those types of provisions in its contract for over 10 years. And because of that, our clients did not experience a lot of the difficulty that rose a couple years ago with clawbacks and other things that you may have heard in the media. So very important provisions, certainly something that should be, in our view, included in every PBM contract. Next slide, please. So now we're going to move into some of what we believe to be the key terms in PBM contracts. And those have to do with the market check. And each of these we're going to go into in a little bit more detail. Those have to do with the market check and audit rights. Then we're going to get into definitions and pricing terms and conditions in a little bit more detail. Next slide. So the market check, that's a provision that it's not common to every PBM contract. Typically, a client has to be of a certain size before they can get a market check. All Employers Health clients enjoy a market check through Employers Health, but essentially, the gist of a market check is most PBM contracts are a duration of at least 3 years. I've seen 5 years, and I've even seen 7-year PBM contracts before. 3 years is an eternity in the PBM world, and 5 and 7 years is obviously even longer than that. Pricing adjusts very fluidly in the PBM industry. Within 1 calendar year, we can see many dynamics that will change market pricing pretty dramatically. And so if you have a market check provision like Employers Health does, you're able to keep pace with market dynamics, and that's the point. And if you do have a market check provision, obviously setting a timeline for commencement and completion is extremely important. I would say that one of the most important elements to a good market check is having competitive intel, market data, making sure that you've got a good stream of data coming into you, letting you know where the market is at. Fortunately, here at Employers Health, we have a dynamic sales team that is out promoting all the time, like Mike mentioned before. So we get constant feedback on what other PBMs might be doing, good or bad. And so we're able to adjust for that. With respect to an audit process, some of the key points are on the screen here, but I think the thing that is not in here, or at least not specifically, that is really worth mentioning is when it comes to a PBM audit, the most important thing by far is all of the pre-work, once again, the work you do prior to the audit. setting up the audit, and then ultimately having a kickoff meeting between the auditor, the client, and the PBM so that every bit of the process can be laid out and expectations can be met. Every minute you spend in preparation pays dividends in the actual execution of the audit. Once an audit goes off track, it typically has a snowball effect that tends to delay the process more and more as time goes on. So great pre-work is a key to a good audit. Next slide, please. Mike mentioned it before, certainly bears mentioning again. Definitions are key in a contract. We've listed some here. Typically in a PBM contract, there is a definitions section, and it's typically contained in the core agreement. And typically the definitions section contains a couple dozen, 3 or 4 dozen definitions that are used throughout the contract. But I think the point that bears mentioning here is that's just that section. In reality, definitions occur throughout a PBM contract. So literally at any point within a PBM contract, there can be terms that may alter or amend or severely limit some of the definitions that are in the core portion of the agreement. So it's really important when doing PBM contracting to understand what is included throughout the PBM contract and how various terms in various sections may play together or not play together. We've listed a few different types of definitions here that are certainly important. The definition of brand and generic, obviously, or at least it's obvious to us, that needs to be based on a nationally recognized drug classification system. Definition of single source generic is also very important, extremely important. Particularly, we find this to be an issue at times for deals that smaller groups may get. So if you are in a smaller group, you may want to pay attention to that. But generally speaking, a single source generic should be one that has one manufacturer and product availability. It should not be 2 or 3 manufacturers. Other definitions that are important, the definition of AWP. This is pretty standard in the PBM industry, but again, something to make sure of in your PBM contract. What you are trying to avoid here is giving the PBM the flexibility to pick whatever AWP they want so that they can meet their guarantees. And then definition of rebates is becoming more and more important all the time. The definition of rebates in your contract should include all different types of all different kinds of manufacturer payments that you expect. And that being market share rebates, access-based rebates, formulary rebates, price protection rebates, and that's one that is relatively new over the past 5 to 7 years, but one that certainly should be in your contract. And if it is not, you should be asking questions about that. Next slide, please. So pricing terms and conditions, we're going to go into this in a little bit more detail, but when it comes to the pricing terms and conditions, you have 2 types of guarantees. These are the primary types of guarantees in each PBM contract, and that is discount guarantees and rebate guarantees. For discount guarantees, you want to make sure that you can validate each discount guarantee for each and every claim type that's out there. We tend to think of claim types as, well, there's mail and retail and specialty, and well, there's brand and generic. But in reality, there's many, many, many other types of claim types as well. And you need to understand how each of those claim types is adjudicated and reconciled and calculated in each of these guarantees. When it comes to rebate guarantees, probably the biggest thing right now to ensure is that you understand the denominator. What is the rebate yield being compared against when that rebate guarantee is applied? And I put some examples down here to illustrate the point. A rebate can be paid against all prescriptions, which would mean a very small rebate guarantee, or it can be paid against just brand RXs, which makes a larger number, or it can be paid against per rebatable claims, which makes yet a larger number, or it can be paid against rebated claims, which makes an even larger number. And the reason why those numbers appear larger is simply because the denominator is shrinking in each of those examples. The numerator is also important. Again, we mentioned it just a minute ago, but price protection guarantees, if those are not included in your definition of rebates, then the amount of rebates, the numerator in that rebate guarantee, becomes smaller. I think another key point that is becoming increasingly important, particularly as specialty medications become more and more part of our claims experience, and that is understanding how the adoption of certain clinical programs may affect the rebate guarantee. If a plan sponsor implements a clinical strategy that has a utilization impact on a drug that the PBM is anticipating getting a rebate on, the PBM will want to reduce your rebate guarantee because of that clinical program. So it's just important to understand how that rebate guarantee will be affected if you have a clinical program that you are interested in implementing, and you want to know that prior to implementing the program. Next slide, please.
Hey, Dave, just as we transition here, there were a couple questions I thought we could answer real quickly. The first one was the consultant. Should the consultant be the ones doing the PBM audit? And do you recommend doing an audit after each market check?
Whether the consultant is the auditor or not, I think that is I don't see any reason why that couldn't happen as long as you have a good working relationship with the consultant, provided that the consultant is a third party to the arrangement. So in those situations where the consultant has their own collaborative and they're also doing the audit work, I would contend that that is a conflict of interest and probably not a situation where the consultant should be doing the auditing, but where the consultant is genuinely an independent third party, certainly. And then what should you do it after each market check? I'd recommend doing it on an annual basis. At Employers Health, we do a financial audit on an annual basis, and the point of that is making sure that each and every claim that runs through the Employers Health program is checked to make sure that the financial guarantees that we've negotiated on our clients' behalf actually gets executed for our clients.
Mm-hmm. Good. Hey, one other one that I think we can answer quickly and relates to what we just talked about. The participant asked, why is it necessary to know all rebates from the manufacturer, such as price protection, market share access, if you're entering into a traditional versus a pass-through arrangement?
Well, I see the questioner's point. At the end of the day, the guarantee is the guarantee, and particularly that is true in terms of what is the source. I think it's more a question of knowing where your PBM is making their money and where they may not be. For purposes of determining the value of the each particular guarantee point, it is true that the denominator is really the place you want to focus.
Yeah, I would just add that, you know, for those that have the opportunity to overperform the guarantee, knowing what's included in the rebate definition will tell you likelihood of overperformance. So for example, one of the big three PBMs doesn't include price protection. They keep that for themselves. They can set their guarantees a little bit higher, which is what ultimately employers are for the most part, are looking at. But when it comes to reconciliation then of the rebate guarantees versus what was actually collected, just remember that what's actually collected doesn't include those price protection rebates. So in almost every case, you as a group are not going to overperform because the PBM is, in that case, keeping a form of that manufacturer revenue. So it gets back to my first point about risk and the ability to, if they're going to set a pricing guarantee, how do they mitigate some of the risk associated with that? And a lot of it has to do with what they consider as a definition of rebate. Okay.
All true.
Thanks, Dave.
Okay. Oh, sure. So yeah, moving on. So the name of these, I've named the next few slides PBM game theory, and this is just to really kind of go over some of the different ways in which PBM can do exactly what Mike said. Mitigate risk, create larger guarantees than what is actually happening. They can make, for lack of a better term, the spreadsheet pop with large numbers by pursuing some of these strategies. And at least for employers' health, we consider it a math game. We just try to figure out exactly how each of our competitors' contracts are structured, how their pricing terms are structured, and then we compare it to our own. Within our contract, our standard is to have an all-inclusive contract where it's relatively easy to evaluate the true value of our contract without having to play a lot of games or rebucketing or things like that to determine the true value. So anyway, this slide talks about the different types of PBM evaluations, and they're relatively simple. There's two kinds. There's one where you're evaluating more than one PBM, that's a multi-PBM evaluation, and there's one where you're evaluating just one, and typically that's where you're evaluating the PBM you're with today. In a multi-PBM evaluation, by far the biggest difficulty is aligning all of the PBM offers to get them on the same playing field. Some PBM offers may exclude certain things from pricing guarantees, others may not, and they may all have different definitions and terms and handle claims in different ways. So the consultant's biggest challenge, I think, is getting all of those in one way or another to align. The best way to do that is if you're in a competitive RFP type of situation, you just make it part of the RFP requirements. But even if that's done, and it often is, PBMs will often submit bids and decline to comply with certain of the requirements. A brief look at that declining PBMs or that PBM that has declined a certain pricing element, a brief look at the rest of their offer may lead one to believe, you know what, even though they've declined this particular portion, it still might be a pretty good deal. So we've got to go ahead and evaluate it. And if that's the case, then what needs to be done at that point is you have to adjust that offer back to the incumbent baseline in order to do a real comparison of the value of that PBM offer compared to what's in place today. Then obviously in all PBM evaluations, a standard part of it should be projecting how the PBM will perform in the future. Same is true with the incumbent PBM evaluation. You don't have a lot of the lineup problems that I mentioned before in that in an incumbent evaluation, definitely the most important part of that is making sure whatever you were negotiating for, whether it's a clinical strategy or whatever other provision you are negotiating, seeing and projecting how that will impact cost and disruption into the future. A big part of that process is, again, market research, making sure that you know what else might be done, particularly by the same PBM out in the marketplace. Next slide. So this slide is intended to show some of the challenges that might go into a PBM evaluation. You have PBM 1 on the left and PBM 2 on the right. PBM 1 on the left, when you look at their price points that they've offered, every one of them is lower than PBM 2 on the right, except for the specialty discount guarantee. However, when you look below, you will see the PBM 1 has an inclusive terms and conditions. Single source generics are included in the overall generic effective rate. Limited distribution drugs are included in the rebate guarantee, and the mail rebate guarantee is based on actual utilization. Contrast that with PBM 2, which has taken single source generics out of the generic effective rate guarantee and put it into the brand drug guarantees. They've also taken limited distribution drugs and excluded them from the rebate guarantees. And they've taken the mail rebate guarantees and based them on 90 days supply rather than actual utilization. All of those tactics have the ability to inflate the numbers that the PBM presents. Go to the next slide, please. And these are just some ways that you might be able to adjust for some of these tactics, but single source generics being included in the brand discount guarantee. The tactic I call claims rebucketing. They've taken claims that would naturally exist in the generic guarantee, and they've taken them out of the generic guarantee and put them in the brand guarantee. And the reason why they have done that is because single source generics typically adjudicate at a discount rate of between 35 to 50%. That's quite a bit less than multi-source generics, which typically adjudicate in the range of 83 all the way up to 90%. So by pulling those out of the generic overall effective rate guarantee and putting them in brands, which also adjudicate typically at a lower rate, they can artificially inflate the brand rate while at the same time inflating the generic rate. So a way to try to overcome this is simply you get the list of single source generics from the comparator PBM. You pull the AWP and discounted AWP for all at a component level for the single source generics, multi-source generics, and brands. You develop the relative value of each of those discounts, and then you just simply rebucket the single source generics back into the back into the overall generic effective rate guarantee. So you bucket those back with multi-source generics where they should be, and then you recalculate what discounts that PBM is actually offering. With respect to limited distribution drugs and excluding them from rebate guarantees, again, this is a denominator adjustment. So what this PBM has done is they've shrunk the universe of claims against which the rebate is paid. These are all claims. These are limited distribution drugs. They've taken that away, so they've created a smaller denominator. By creating a smaller denominator, the quotient goes up. The way to overcome this is you obtain a list of limited distribution drugs from the comparator PBM. You determine the proportion of limited distribution drugs as compared with all claims, and then you simply multiply that by 1 minus the proportion of 1 minus the LDD proportion divided by all claims, and that's how much you reduce that rebate guarantee by to determine how much it would be worth as compared to a program that includes all claims. And then finally, rebate guarantees based on days supply. The tactic here is guarantee proration. You'll see in various PBM deals certain guarantees that are based on days supply. In this particular case, I based it off of a guarantee that just applies to mail, and that's why you'll see the numbers 90 in here. But you will also see them sometimes based on retail as well. And then obviously in that case, you would base these numbers on 30. But the way to overcome this particular type of tactic is you determine the actual average day supply that is being used by the channel in question. You subtract that from 90 if it's mail or 30 if it's retail. Then you take that difference and you divide it by 90 or 30. And then you reduce the rebate guarantee by the percentage determined by that quotient. Next slide. You know, a question that often gets asked, and I think this is something that is getting more and more play, and that is differing specialty lists. So I know we are at the top of the hour, and I'll try to make this quick, but there's really two types of analyses that you want to do. If you're trying to equalize lists simply for cost evaluation, you just need to rebucket the claims. You need to take the claims that are in one PBM's offering and not in the other and reprice those according to the non-specialty guarantees. And then you need to do the opposite for the other PBM as well. And then you simply reprice the claims according to how you have shifted or rebucketed the claims. And that will play into the overall evaluation. But if you're really looking to determine the overall cost effectiveness of a specialty list, you need to include the rebate yield as well. Essentially, you're doing the same thing by rebucketing, but in this case, you are determining the cost of particular specialty medications at the specialty pricing versus non-specialty pricing, then subtracting that result from the rebate yield. And that should give you an overall view of which specialty list is more cost effective. Next slide. Some final notes on specialty drugs and limited distribution drugs. Specialty drugs are typically priced through an overall effective rate discount or overall effective discount. And this is just a blend of the brand and generic discounts that are produced by the specialty drugs. The more generic utilization running through a specialty program, the higher the OED should be. Limited distribution drugs are commonly excluded from many rebate deals. I think the point here is that limited distribution drugs typically have low discounts because there's not a lot of them. But also whether a drug is considered limited distribution drugs or not is first up to the manufacturer. The manufacturer can designate a drug to be limited distribution or not, and then the PBM. Certainly PBMs have the ability, or at least some of them do, depending upon contract language, to call more drugs than what the manufacturers are claiming as limited distribution. And certainly not all limited distribution drugs are equal. Some have many more drugs on their limited distribution lists than others. Next slide. And then I'll close with this: formulary evaluation, certainly a key part of any PBM evaluation. The best we can do here without drug level rebate information is just by going through these steps, really end up knowing how is the PBM making their rebate guarantees. Is the PBM formulary one that prefers a lot of high cost, low value drugs or excludes a number of other lower cost options in favor of higher cost options in order to drive up rebates? So if you do have a PBM formulary that has a lot of low value, high cost drugs or a lot of exclusions, you would expect to see that PBM have a very high rebate guarantee, comparatively speaking. So that was a lot to cover in a short period of time. Obviously, we're not going to have time for questions and answers, but please do submit your questions to us and we'll make sure that you get a response.
Yeah, absolutely. Thank you, Dave. And just a couple takeaways that I put on the last slide here that you can take a look at. Again, the handout of the slides are over on the control panel. But certainly, I think hopefully one thing that you took away from this is the marketplace is changing. PBM contracts can be very intensive, and you need help. I always joke that it takes a village to figure all of this out, and as Dave referenced earlier, just the idea of getting the market intelligence and building the relationships across the industry to be able to talk with different consultants, different PBMs, obviously all of our clients, to try to figure out what gives us the most bang for the buck is something that we spend most of our days doing, and have certainly led to where we are today, and certainly appreciate the work that Dave has put into making our contract what it is today. So again, if you have questions, please do submit them. Make sure you fill out the survey when you exit. And thank you again for taking the time to be with us today. Again, stay safe out there. Wishing only the best for you and your families as we continue to work through this situation together. But certainly appreciate it. Hopefully you'll join us on our third PBM webinar, which again I'll be joined by Matt Harmon, who leads our clinical pharmacist team, and we'll dive into specialty pharmacy. So again, thank you. Enjoy the rest of your day.